Doctor, you can start a meeting. We are in live now.
Yeah, we can start.
Shall we, sir? President?
Sure.
Yes.
We can go.
Please, all of you mute. At the outset, wish you all a very, very happy and prosperous New Year 2025. And with our President 2025, very dynamic, very active, who has planned meticulously this program of Triple E, Dr. Vasant Kalekar, sir. We are very proud, sir, to be this program of Triple E going to be inaugurated today. I welcome, as a member of this committee, all the dignitaries, stalwarts who have come here. Now I request our HSG, Professor Dr. Yogesh Parekh, to deliver his welcome address in this forum. Over to Yogesh ji. Yogesh sir, are you there?
Yogesh, can you unmute?
Thank you. Hello. Hello, I'm audible.
योगेश भाई ऑडिबल नहीं हो आप।
थोड़ा नेटवर्क का इश्यू है सर, स्टार्ट करो सर। यस सर, प्लीज स्टार्ट।
Okay. So, here today, the 1st January, Indian is launching the Triple E program, education by the of the expertise, bridging the expertise and the experience for the excellence in the pediatric practice. And today we have a chief guest, president from the Philippines. So here I will.
Not audible, sir.
Program Dr. Expert Dr. Vijay Ole sir, Dr. Thangavelu sir as from the advisor of this program, and Dr. R. Palniraman and Dr. Shobna and Dr. Shashidharan Kundaswamy as a mentor of this program. So this is the new initiative by the team 2025 of the Indian Academy of Pediatrics. We are having some few academics programs. Last year we have launched the epidemics of the academics, and this year we starting this program. So here I welcome all the office bearers, vice presidents, executive board members, and all the digital the delegates on the digital platform of this Indian Academy of Pediatrics. So I welcome all of you. My dear friend Dr. Atanu Badra is here to support all these academics events and the financial support. So please go ahead. I am facing some network issue. Please go ahead. So Dr. Atanu will take care of this program afterwards.
Thank you, sir. Thank you, HSG, sir, for your nice words in spite of your busy schedule of traveling. Thank you, sir. Sir, as sir has told, this unique club, education by essence of experience, which is our president who thought uniquely where he want to bridge the experience with expertise so that he want to deliver some message to the practicing pediatrician. This, for which this program was launched on the year first. It is a very flagship program of our president, Dr. Vasant Kalekar, who meticulously planned within a very short time. We are very happy that all stalwarts of past presidents are here with our chief guest. Now, I request our president, Vasant Kalekar, to deliver his New Year come welcome address. This we are going to hear our president first in the January itself. Welcome, sir. President Vasant Kalekar,
Thank
sir.
you. Thank you, Singal Velu, sir. So, since Yogesh sir is facing some problems. We'll
Oh, you are continue. Okay, you
yeah,
continue.
we'll
sir. Sorry.
continue from here, and we'll
Yes.
request our president taking charge from midnight of 1st of January. And since this is an Indian Academy of Pediatrics, so Dr. Vasant Khaletkar decided to start it with an hardcore academic program. So your address, please, President Sir, for 2025 first academic program of 25. Dr. Vasant Sir, yes.
Please unmute, sir.
Unmute.
Namaste, good afternoon, all, and a very warm welcome to Indian Academy of Pediatrics. Respected Dr. Jocelyn, who is Associate Alonos Isobio, who is Associate Professor, our President-elect, Dr. Neelam Mohan, our President, past President, Dr. G.V. Basavaraja, our Dynamic Secretary, Dr. Yogesh Parekh, our Treasurer, Dr. Atanu Bhadra, who is National Treasurer, my office bearer, my executive board member, and all the contributors for this program, dear colleagues, members of IAP, and esteemed guests. Good day and a very warm welcome to all of you. Wishing you all a very happy and prosperous new year. I hope you and IAP both should prosper simultaneously. Today is a special as we launch EEE, that education by essence of experience, an initiative that embodies what the IAP truly stands for. Learning from one another to improve child health. EEE is not just another program, it's a platform to share the knowledge and wisdom we have gathered over the years. As the pediatricians, our experiences shape how we care for children and mentor the next generation. What we are in student, it is the different when you get experience, and that after 10-year practice, 20 years practice, you are getting a different. Initially, you practice to get the patient, you get a patient. But later on, as you get older and older, you practice to maintain your name, fame, and your everything. Not money is secondary than that. So, though through this initiative, we aim to learn together by discussing real life cases and practical lessons, support growth by guiding and inspiring younger members to think creatively and critically, work as a team by fostering collaboration across regions, specialties, and generation. Experience is a powerful teacher, and by sharing what we have learned, we can inspire and equip future pediatricians to provide the best possible care. So this is the best thing in in our medicine, that we learn by experience. We teach other, we never keep it. If you take the example of other branches like engineers, CA and everything, they never teaches themselves by experience, because they never share the experience. We are the only persons who are doctors. We share our experience, and that's why we came here. How the concept came in mind. I had one patient who had a very road accident, came with to me just for observation. I thought I will keep that girl, 4-year-old girl, to just for observation. And within, when I examined her, I found that there was a systolic murmur and in chest. So I thought, I asked the patient's relative, is there any congenital heart disease you noted in past? They said they were not educated, and they were saying, oh, yes, sir, yes, sir. Somebody told me that there is a cardiac problem. I thought this must be ventricular septal defect. And I kept the patient just for observation in my indoor. Within 4 or 5 hours, the saturation got dropped down. Then I shifted to our critical care, and where the patient got ventilated. We were not getting anything. What is the going on happen? Patient was ventilated. There was pleural effusion, failure, and everything. Somehow that time we had no facility of eco, unfortunately, that time. Then we could manage a eco after 10 days, and that was showing that there was a mitral incompetence due to muscle tear, and that turned out our diagnosis. And that day I thought that there should be something, we have to discuss cases, that what we are missing. It was just we couldn't make the eco. We could make, otherwise then patient got all right. We shifted to cardiothoracic surgeon, and now the patient is absolutely all right, but we lost our 10 days for that, just because of our misdiagnosis. So I would like to extend my heartfelt thanks to our office bearer, starting with Dr. G.V. Basavaraja, our immediate past president, Dr. Neelam Mohan, our president-elect for 2025, our dynamic honorary general secretary general, Dr. Yogesh Parekh, and our national treasurer, Dr. Atanu Bhadra, our vice presidents, Dr. Prashant Sabot, Dr. Pemde, Dr. Bajania, Dr. Preeti Galgali, and Dr. So, and my special executive member and all our experts who contributed for this program, Dr. Bela Verma, Dr. Jitendra Gawane, Dr. Nehal Patel, Dr. Ravi Krishna, Dr. Ramakrishna Paramahansa, Dr. Ranjandeep Das, Dr. Kalpana Datta, Dr. Shashidharan, Dr. Vijay Rajan, Dr. Jose, GP Kaushal, Dr. Ajay Gaur, Pancham Kumar, Vijay Kulkarni. All these are from different zones. That is the south, east, north, and west zone. We are having a this zone wise, and we are very they help me lot. So as I want to say thank you once again for all those. As we launch Triple E, I invite all you to contribute, share your stories, mentor others, and participate in the learning opportunity it offers. Together, we can make Triple E a platform that transforms how we teach, learn, and grow as a community. This new year marks a fresh start, and with your involvement, I'm confident that Triple E will be a remarkable success. Let us make this initiative a proud achievement for IIP and a meaningful gift to future pediatricians. Before I thanks, I invite you all for Hyderabad Pedicon that is going to held from 8 January to 12 January at HICC Hyderabad. Thank you for your dedication and for joining us in celebrating this milestone. Here is to year filled with learning, growth, and positive impact to serve my children, colleagues, and country. Thank you once again. Jai Hind, Jai IIP.
Thank you, Vasant sir. So the whole of IIP will rise to the occasion to make your tenure a successful one, and something well begun is already half done. So that's, we firmly believe in that concept. So it's well begun on the 1st of January. So before we proceed with the inauguration, I would request Professor Thangavelu sir to give a short concept note of what we are going to have in this programs in the next sessions and also this session. So I know you would be conducting this session, but just if you can come out with just a few concept note for all of our dignitaries. Professor Thangavelu sir. Yeah.
Thank you, Badra sir. Good afternoon, President Vasant Kalatkar, Appa President Jocelyn, President-elect Madam Neelam Mohan, my dear friend Professor J.V. Basavaraja, HSJ Yogesh Parekh, Hatanu Batra Treasurer, my dear friend Dr. Singaravel VP, Vijay Avel, and all the senior teachers. I'm extremely happy and proud for giving me this opportunity to introduce this interesting program, a brainchild of our president. Learning from one's own experience is very expensive. At the same time, there are many opportunities for us to learn from others' experience. President wanted to organize a program based on this concept. In early 1990s, I also had a similar problem what our president explained. I was working in a small PHC. A 3-year-old child was brought by parents. We were sitting in a mother's lap with closed eyes as if the child was sleeping. Mother also said the child is sleepy most of the time, last 2-3 days. No fever or seizures. I asked the parents any chance the child has taken cough cold medications to explain the reason for unexplained sleepiness. Even then, I wanted to look at eyes. It's a remote village. Good torch was not available early. They were searching for the torch and finally bought a new torch and brought to me after an hour. When I opened the eyelids and looked at the pupils, it was a shocking experience for me. It was a white reflex on both sides. Later proved as bilateral retinoblastoma with the ophthalmologist, which made me to mistake as excessive sleepiness. But for looking at the pupils using a torch, I would have made a great blunder of missing a treatable tumor and delayed the initiation of a treatable cancer. See, every one of us would have had a similar bad experiences. That's what we are going to share with you all, with everyone's benefit. At the same time, it is a very sensitive subject. So topics are chosen in such a way that in a very cautious way. Today, we are going to present 2 case scenarios. First case is a complex case from pediatric intensive care unit of Mehta Multi-Speciality Hospital, Chennai. Mentor is that a case Sasidharan is a pediatric intensivist and head of the department of PICU. And presenter is Dr. Shobana, DRNB fellow. Time for presentation is 45 minutes and 30 minutes for discussion. Second case scenario is presented by none other than our dear friend Dr. Palninaman, a rare breed of practicing pediatrician with an abundant academic excellence from a small town in Tamil Nadu called Dindivanam. He is known to everybody all over India. His presentation time is 15 minutes for presentation, 10 minutes for discussion. With this, I close my introductory talk and hand over the mic to the organizer, Dr. Singaravelu or Dr. Batan Batra. Thank you.
Thank you. Thank you, sir. So we're looking forward to your concept as it comes out, as it rolls out in this whole year. Sir, we all know that IAP is about 3 Ps, the 3 presidents working together, and we have seen this synergy in year after year. And this time we are fortunate to have a thorough academician, Dr. Neelam Mohan, as our president-elect. Neelam ma'am, we want to hear from you a few words before we start the hardcore inauguration. So Neelam ma'am.
Good evening, respected and popular President Vasant Kalatkar, the chief guest Jocelyn, and the past president Dr. Baswaraja, Dr. Upendra, the concept programmer Dr. Thangaravelu, as well as the other team members who are with him, Singaravelu and the other team members. It is indeed a proud privilege to see that on the first we are starting with an absolute wonderful academic program, which is very insightful because as doctors, we spend years immersing ourselves in books, lectures, rigorous training. But yet we know that medicine is as much as an art as it is a science. And the most valuable lessons often come not from the textbooks, but from real life experiences. A wise person said, while knowledge is knowing what to do, wisdom is knowing how to do. And it is this wisdom which comes through experience, reflection, and sometimes our own experiences, and sometimes learning from the experience of others, who shape us into better professionals and, more importantly, as good human beings. And in this program, which is the brainchild of beloved, versatile Dr. Vasant, this program, we will explore how we can learn from the experiences, both from our own and others, and transform the way we approach patient care, decision making, and discussion, which will happen, which will eventually lead to good patient care, personal growth, and each story, as they are talking about the case with that discussions, will make us wiser into this. Without taking more time, I would take this opportunity to share that we, as a community of healers and learners, and thanks all the EB members and the other seniors who have joined today, wish to enrich this experience and wishing you all a very happy new year, which is full of opportunities, health, which includes physical health, mental health, social health, which we are doing right now, and spiritual health, which comes through selfish insights. Thank you for this opportunity, and I wish everybody good luck in this program, which will enlighten us more and more.
Thank you, ma'am. Thank you. And Dr. Basav sir, after having a breakneck speed year of 24, wanted one day off this day, but the IAP organization could not allow him 1 day's leave. So we had to, and he has joined today. We are thankful that he has joined today. Basav sir, we want to hear a few words because it's your flow of events that is finally going on this year also. IAP is deeply embedded in academics. Dr. Basav sir.
Thank you very much, Dr. Atanu Badra. Respected our National President of Indian Academy of Pediatrics, Dr. Vasant Kalatkar ji. And our chief guest of today, Professor Jocelyn, who has been conducted a memorable conference at Philippines. And our President-elect, Dr. Neelam Mohan, and Honorary Secretary General, Professor Yogesh Parikh Atanu Badraji, our National Treasurer. Hitting on the first day to the ground and taking the academics to the greater heights, that shows that how much our Honorable President, National President of Indian Academy of Pediatrics, Dr. Vasant Kalatkar, has committed to the academics and organization. Dr. Vasanti was planning this program for a quite long time with a well-experienced stalwarts in the field of pediatrics, Professor Thangavelu. Thangavelu was a Dian in the field of pediatrics emergency and critical care, which is supported by Dr. Professor Singarvelu. And look at the way they have chosen two cases, one from the periphery, another from the metro, so that it is there for a practicing pediatrician, it is there for the people who are working in a tertiary level intensive care unit also. Most of the time when I talk every day in my postgraduates in a emergency and a pediatric intensive care unit, I'll tell them, your life is very short. You cannot make all the mistakes. You need to learn from other mistake or other experience. That's how the beauty of a medicine which is going to be. So I'm sure Dr. Vasantji, who has been chosen this thing with an expert like Dr. Vijay Avale, Shashidharan, we know all of them were thorough academicians. This program is going to make a big history in the Indian Academy of Pediatrics. Our Upendarji definitely will agree with that because he was closely following this thing. So thank you all the post OB member, EB member, and all the seniors who has been joined. And please make use of this program and join every Monday with every week, once in a month, in a big way, and make use of this program. Thank you very much.
Thank you, Basav sir. Thank you. So now is the time to hear from the chief guest. I would request our President, Dr. Vasant sir, to please introduce to the chief guest, Dr. Jocelyn from APA. Vasant sir.
Yeah. Unmute. Yes, I am sharing the slide. Give me. I really want to welcome Dr. Jocelyn C. Alonso Isobio. Really, before introducing, I want to thanks my Vice President, Dr. Guru Prasad, to whom I miss mentioning. So again, all those names I have missed, please excuse me. And here is Dr. Jocelyn C. Alonso Isobio. She is MD, FPPS, DBP, and she is actually development pediatrician. To introduce her, it's my pride, it's my honor. She is a doctor of medicine at URM MMMC since 1982 to 1994. She had done. She had residence in pediatric, Department of Pediatric, that same institute from 1987 to 1989 and done fellowship and developmental behavioral pediatric from UP PGH in year 1990 to 91. She has done international fellowship in developmental and behavioral pediatric that's on Children's Evaluation and Rehabilitation Center, New York, USA in year 1995. She is a fellow Philippines Pediatric Society, fellow Philippines Society for Developmental and Behavioral. At present, she is associate professor in College of Medicine in the same institute where she learned lot. Past chair Department of Pediatric from year 2017 to 2021. She was immediate past chair Department of Pediatric National Children's Hospital from year 21 to 24. She is at present associate professor at St. Luke's College of Medicine, instructor College of Medicine New Era University since last 7 years. She was President-elect Asia Pacific Pediatric Association, that's APPA, from June 22 to November 15, 24. Standing Committee member APPA from June 22 to November 24. She is a council member, Asian Society of Pediatric Research, Vice President, Philippines Association for the Gifted, and still now she is Vice President. She was the past President, Philippines Pediatric Society, that's from year 20 to 22. Immediate past President, Perinatal Association of Philippines, and past President, Section of Developmental and Behavioral Pediatric, National Children's Hospital from 1992 to 2010. So the past President, Philippine Society for Development and Behavioral Pediatric. She is Child Development Consultant at UERMMC, National Children's Hospital also, and St. Luke's Medical Center. At present, she's known why she is here. She is the president of Asian Pediatric, so that's APPA. Not only this, but
Yeah, Vasant sir.
Not audible, sir. Vasant sir, I think network issue.
I think he's frozen.
Aye.
Yeah.
Would
I
you
think,
like?
yeah, madam. Yes, Jocelyn,
Yeah,
ma'am,
yeah.
please,
Would
yeah.
you like me to go ahead?
Yes,
Right,
yes,
so-
please, ma'am, please.
Okay, Dr. Vasant Kalatkar, President of IAP, Dr. Nilan Mohan, President-elect, Dr. GV Bazavaraja, IAP's immediate past President, Dr. Yogesh N. Parikh, Secretary General, Dr. Atanu Badra, Treasurer, all the stalwarts, the past presidents of IAP, the organizers, advisors, and presenters for this program, guests, dear colleagues in APA, good day. First, I would like to extend my sincerest gratitude for the honor and privilege for being a part of this significant milestone of the IAP. I'd like to congratulate the IAP for coming up with this concept of education by essence of experience, a philosophical theme that touches on two important educational philosophies: essentialism and experientialism. I thank you for making this project yet another of your, I must say, concrete contributions to the Asia-Pacific region. Thank you for this progressive initiative by your academy. EEE indeed has a place in the practice of pediatrics, especially in this era of technology. We want pediatricians actively participating in their own learning journeys, asking questions, reflecting, and even questioning their interactions with the world. These qualities will hone them and most likely make them better pediatricians. This transformative initiative does not only enhance the intellectual journeys of pediatricians, but it promises to strengthen emotional levels of doctors, which I believe will ultimately benefit our little patients. In our pursuit of furtherance, we must remember that the most profound lessons come from not the cold letters of a textbook or the content of a lecture but from the live experiences of people. Genuine education is more than just knowing. It involves looking, listening, doing, and reflecting. Education builds competence. Experience builds resilience. We must lead by example by showing the future pediatricians how. We must create an environment conducive to meaningful and deep learning by following the roadmap, putting the guardrails, and setting up the guideposts to minimize obstacles and hindrances. Education is not just what we know, it is how we apply and grow. Let the essence of experience guide our way. Thank you and good day. Happy New Year to everyone.
Thank you, ma'am. Thank you.
Thank you so much.
Thank you, madam. Madam, I lost my connection actually. I could have said for 2-3 minutes, sir. Thank you for coming as the chief guest. Sir.
Thank you so much.
Thank you, ma'am. And I hope that IAP and APPA, the coordination and cooperation among all the countries of the Asia Pacific will be increased in this year. So we are looking forward to it, ma'am.
Yeah, thank you so much.
Okay, so we move to the now the actual program. So we have an expert, our past president. In fact, he was my first president when I was EB, Dr. Vijay Ivale. So to introduce him and to ask him to come on the platform, I would request Dr. Jitendra Gawane, the silent background worker, dear friend Dr. Jitendra Gawane, who had been fortunate to be working closely with Vijay Ivale sir in Navi Mumbai. So, Dr. Jitendra, please.
Yeah. So, good afternoon, respected dignitaries on dais and the people who are watching this program. So today's expert we have none other than Dr. Vijay Ivale sir. Sir doesn't need any introduction. First quality of him is a greatest human being. He has helped each and everyone whosoever has asked, whether it is academic help or any other personal help, and he has touched many lives and hearts. He's an astute clinician and academician heading the Department of Pediatrics at Apollo Hospital, Navi Mumbai. He was a ACVIP chair from 2010 and 11, and he was president of Indian Academy of Pediatrics in 2014. Sir, you have given a voice logo, that NARA of AAA, that is avoid antibiotic abuse to IAPNs, and 10 years down the line, Vasant sir is giving EEE to all academicians. So, sir, I welcome you to this platform, and I request you to say a few words.
Well, at the outset, thank you very much, Jitendra, for those kind words of that you uttered for me. I do not know how much I deserved of it, though. At the outset, let me congratulate Vasant for assuming the chair of the Indian Academy of Pediatrics, which is one of the largest body of academicians, pediatrician members in the world, I believe now, with nearly 50,000 members. The respected dignitaries who are present on the platform, the immediate past president, Dr. Baswaraj, the president-elect, Dr. Neelam, and my several other fellow past presidents who are there on the platform. The hardworking, the Honorary Secretary of the Indian Academy of Pediatrics, Dr. Yogesh Parekh, the Treasurer, Dr. Atanu Bhadra, who always chips in whenever Dr. Yogesh is out or is unable to continue on the platform. And that's really commendable and appreciable. And the chief guest for today's event, Professor Jocelyn from Philippines. And so I'm extremely happy that Vasant started his tenure with a bang. which is very much in sync with the ethos and mission of the Indian Academy of Pediatrics, that academics and advocacy. Now, when I came to know about this program, about EEE, as Jitendra said, it really, made me nostalgic about AAA. But EEE is something which is really something which is very innovative, and all of us are pretty well aware of the famous saying that medicine cannot be learned in books, and medicine is always learned on patients. And all of us, being human beings, are keep learning from our patients and our experience. Our patients are our greatest teachers, and the beauty is to learn from the experience, or into inverted comma mistakes, and then try to improve upon them. And here is a platform where there is an opportunity to share our experience and the mistakes that we have made, and so that the fellow colleagues and the future generation of pediatricians learn from the experience, and ultimately the mission of helping and curing our children is achieved. So this is a really extremely important initiative that has been started by Dr. Vasant Khalatkar. And I'm told that there'll be 2 cases, and I'll fail in my duty if I don't mention that no other academician from the academy other than Dr. Professor Thagavellu and Sengarvellu would have been better to steer this program. And I'm sure with their expertise and experience, there'll be a lot to learn for all of us. And I look forward to this opportunity to learn from the experience. I once again thank the Indian Academy of Pediatrics for inviting me for this inaugural program, and giving me this opportunity to witness 2 interesting cases, which I'm not aware of. And I would make a plea to all the to Professor Thagavellu and Sengarvellu that let the experts be not aware of these cases beforehand, so that there is true learning, and it would serve the purpose. I once again thank each one of you, and thank you so much, Professor Jocelyn, for joining us on this academic platform of the Indian Academy of Pediatrics. Thank you so much. Look forward to a very good experience and learning from all of you. Thank you.
Thank you, sir. Thank you, sir. So I hand over the person who had been working hard to put this in, steering this program. Dr. Singaravalu, sir, it's your platform. So please conduct the program as you have planned. It's your planning, it's master planning. So we are with you. And on behalf of our Secretary General, Dr. Yogesh Parikh, and myself, we are there with the team. So that please go ahead and start. You can also, in between the program, you can ask Dr. Digant Sastry, Dr. Pramod Jog, and Dr. Upendra, or past presidents, to put their comments after the cases are over. So, yes. Singaravalu, sir.
Thank you. Thank you, our national treasurer, sir, first national treasurer, Dr. Atulu, sir. And thank you, Vijayavali, sir, for nicely putting your remarks, sir. Yes, sir, the cases which will not be disclosed openly, then there will not be interest for the participant to go ahead and to learning. That is what our president aimed, and Thangavelu, sir, who along with me, we are planned, sir. Without wasting much time, once again, I thank all the dignitaries, all the past presidents, all the stalwarts who was assembled here on the first day of this new year. Surely this program, with your all experts and experience and comments, will go ahead further well, and the vision of our President Vasant will be executed nicely for better learning of our practicing pediatrician as well as the consultants. So with this, the concept is we have 2 cases. The first case is a long case, and second case will be a short case, where we want to deliver the material and learning both for the experts as well as the practicing pediatrician. And it is a very open platform. After the end of the session, Yogesh sir will make good comments, following which others also can contribute, so that all the viewers will be benefited. It is apart from Zoom, it is linked by other means, so that so many viewers are there, so that it will be benefit. So with this, I first call upon Dr. Sasitharan, who is going to be the expert for this case, and he is one of the very popular critical care pediatrician and a pediatric nephrologist also, and he is heading the critical care department in the Mehta Multi-Speciality Hospital. And with him, his team, Dr. Shobana, is a person doing DNRSP, super specialist in critical care. So this team, under the leadership of Dr. Rangavel. Now I request Dr. Sasitharan to take over, then to Shobana to present the case. Dr. Sasitharan, sir.
Thank you, sir. First, I say my gratitude to the IAP for considering us for the first program of the year 2025. This is maybe the best way to start the academics with the full force and say great new year ahead. So with this, we will directly go to the program, and I request Dr. Shobana to share the slides and proceed with the presentation. We start with the long case presentation first. Right. Over to Thangavelu, sir. Sir, if you have any words to say, and then we can start the program.
No, we can just start the program now without delaying.
Yeah. Shobana, can you share?
Yes, sir.
Please. You can start the program right away. Right.
You can make a slideshow.
Going back.
Yes, sir.
Yes, please. Sir.
But going back at a
Yes, sir. Good evening to everyone, professors in this discussion, and a very happy new year to all. Waiting you all for our program in 2025 on behalf of the eminent teachers and professors EEE program. Our team members in Mehta Hospitals, PICU consultant Dr. Sasidaran sir, and pediatric consultant of this case Dr. Gauri Shankar sir, and our pediatric endocrinologist Dr. Hemchand sir, and other super specialists involved in this case are mentioned. And to highlight, today case discussion is about a child, 3-year-old female child with a case of new onset type 1 diabetes mellitus with severe DKA with complication. So the child presented to us with the chief complaints on 22nd of October in 2022. It is a 3-year-old developmentally normal female child who presented to us with history of fast breathing, reduced frequency of passing urine for 1 day, and there was a history of decreased oral acceptance. And mother has given a complaint of weight loss around 2 kg noted in last 2 weeks. And there was a history of polydipsia, but no history of fever, cough, cold, loose stools, or altered sensorium in this current episode. For this current episode, child was treated outside with oral ORS, and child was referred here in view of tachycardia and dyspnea noted by referring physician. Specific history of past illness, around 2 weeks back, prior to this current presentation, the child had outside PICU admission for 3 days in the child's hometown. There was a complaints of fever, cough and cold, and fast breathing, and the child received oxygen support, nebulization, oral steroids, and oseltamivir. And the outside investigation is the child which they have brought showed total count was elevated 10,200 with neutrophilic predominance 68% and platelet of 8,34,000, and we could not trace the other reports. With this, with the possible diagnosis of probable respiratory viral infection, we made the diagnosis of probable respiratory viral infection. And here, in this scenario mentioned, with the possibility in the setting of fast breathing, the 2 possibilities which can come to our mind, the first one is the bronchopneumonia, since the child presented with fever, cough, cold, and fast breathing. And in this scenario, after we made out that it's a case of diabetes mellitus, in retrospective we analyzed this could be a probable acidotic breathing in DKA. Just to highlight the learning point in this thing, I'll just start the video, sir. So the first video, which I'm showing the child with this NRM mask, is acidotic breathing. In acidotic breathing, the child has increased depth and rate of breathing. This type of breathing is mainly to expel the carbon dioxide outside to correct acidosis. I think the video is very evident. In the next video, due to bronchopneumonia or alveolar involvement or pneumonia, when there is an alveolar involvement and there is hypoxia, there is a sensation of air hunger and insufficient airflow. This leads to increased frequency and the rate of the breathing. This is the video of a child with asthma where there is increased rate where inspiration is not prolonged, whereas in this video, comparing these two videos, inspiration is much prolonged in this. This is for our understanding. Yes, with this, with the complaints mentioned, child presented to us in the ER. At the presentation, initial presentation, the child was dull looking, but neurologically child was normal. There was no meningeal signs and airway was maintained with no pulling of secretion. And respiratory wise, the child had tachypnea and subcostal retraction was there with acidotic breathing noted, and bilateral air entry was there and chest was clear, and child was maintaining saturation 98% in room air. And heart rate tachycardia was noted, pulses were well filled, perfusion was well maintained, and child was afebrile, and there was no other disability, no rashes was noted. Based on this, in the initial assessment, the physiological characterization was respiratory distress. With this, the CBG which was done showed 446 and ketone of 4.5 elevated, and the VBG showed severe metabolic acidosis, pH of 7.09, PCO2 16, and bicarb 4.8. With this scenario and this blood investigation, we made the diagnosis of severe DKA. The child was started on oxygen by mask at 5 liters per minute in view of dyspnea, and child received 10 ml per kg NS bolus over 1 hour for correction, for the dehydration correction, and the child was started on 8.5% dehydration correction over 48 hours along with the maintenance fluid. And after 1 hour, the child was started on IV insulin infusion at 0.05 unit per kg per hour. With this, the child was shifted to PICU. In PICU, the child was awake, responding to commands with no meningeal signs. And on general examination, there was no pallor or lymphadenopathy. And other general examinations, in skin was normal, in eye there was no congestion or discharge noted, ear canal was normal, throat was normal, and genitalia was normal. In the initial investigation showed there was an elevated total count 17,100, the thrombocytosis platelet 8,34,000, and in the electrolytes sodium was 126, and the corrected sodium according to the CBG came out as 128.9, bicarb was low 3.9, CRP was positive 23, and HbA1c elevated 14.6. With this, the initial treatment, the treatment which was started in the ER was continued in PICU. The child was continued on O2 by simple flow at 2 liters per minute and continued on the same IV dehydration correction 8.5% and the IV insulin. The correction of DKA. The correction, the dehydration correction got over after 48 hours and the pH gradually improved. At around 36 hours of admission on repeating the pH, improved to 7.31 and bicarb of 8.1. And the anion gap at initial presentation was 23.5, which came down to almost normal 14.9. And with this, the IV insulin correction got over and the child was shifted to oral feeds and subcutaneous insulin at around 48 hours of PICU admission. In this time, we noticed there was a progressive increase in the left upper eyelid swelling and fever started at around day 2, day 3 of admission. But there was no nasal discharge and the oral cavity was normal. In this clinical presentation, the differential diagnosis kept are either preseptal cellulitis, next is orbital cellulitis, which can be, the etiology can be fungal or bacterial. So, for us to understand, there are different terms, preseptal and orbital cellulitis. It is just the disease pathology and the stages involved in the disease progression. Stage 1 is the preseptal cellulitis, where the child presented with eyelid swelling, redness. Then the inflammation extends into the orbital cavity. It is called orbital cellulitis. It is inflammation. When the pus started collecting, it was periosteal abscess. When the pus extends throughout the orbital cavity, it is orbital abscess. When the orbital abscess started, the patient tends to manifest ophthalmoplegia. There was a restriction of extraocular movements noted in this video, in this picture. In the stage 5, when the cellulitis involves the soft tissue around the optic nerve, this can lead to cavernous sinus thrombosis due to involvement of the superior ophthalmic veins. These pictures are not the pictures of the index child. This is mainly for these are the adult pictures which are put mainly for our understanding. So next, coming to the possibility of bacterial and fungal orbital cellulitis, Bacterial orbital cellulitis is most common and it involves Staphylococcus. After the age of 15 years, that can be a most commonly mixed infection can happen. And the treatment of choice for IV is, and bacterial orbital cellulitis is IV cephalosporin and aminoglycosides. Comparing to this, the fungal orbital cellulitis is more common in immunocompromised patients, mainly in DKA, leukemia, neutropenia patient, lymphoma, solid organ transplant patients, etc. And the most common organism in fungal orbital cellulitis are Mucor aspergillus candida. And the treatment is also IV liposomal amphotericin B, followed by posaconazole, voriconazole, or itraconazole, which we'll be discussing later in this case. And the duration of the treatment in bacterial is for 1 to 2 weeks IV, followed by oral of 1 to 2 weeks, where the symptoms and the disease pathology can be controlled with this duration, where more than 90% respond without surgical intervention. Whereas in fungal orbital cellulitis, longer duration of treatment is warranted and there is a frequent need of surgical debridement. So coming to the index child, with this clinical scenario, we did investigation. As per the ENT advice, CT paranasal sinuses and orbit was done, which showed there was a soft tissue thickening in the nasal cavity, nasal septum, and involving bilateral maxillary and ethmoid sinus. And there was a minimal soft tissue inflammation also noted over the medial side of the orbital cavity. So on this, we have secured the central line as the child needed prolonged ICU stay and the prolonged need of the antimicrobial therapy. And initially, child was started on injection fluconazole and injection piptas, as we are not sure of the etiology. With the high possibility of fungal etiology, the antimicrobial was upgraded to injection liposomal amphotericin B and injection flucloxacin. And blood culture, nasal pus culture sensitivity was sent, which later showed no growth. So initially, antifungal, what to choose? On the suspicion of fungal etiology in the scenario of immunocompromised state, the initial empirical antifungal can be triazole, the first generation fluconazole, itraconazole. They covers most of the Candida species. But with the suspicion of mucormycosis, the amphotericin B, it works well against Rhizopus and Mucor species. Whereas in immunocompromised state, in states like neutropenia, the combination of antifungals can also be tried. So with this, the next intervention which we were thinking is about the FES. So FES is actually a minimally invasive endoscopic surgery where the nasal endoscopes are introduced for visualization of the nasal mucosa, the sinus openings, everything. So in this is mainly used for establishing the diagnosis and for necrotic tissue debridement. On debriding the necrotic tissue, we can limit the disease progress and by improving the outcome of the child. So the intervention done in this child is FES. It was done by the ENT surgeon under total intravenous anesthesia. This was the sample taken. The procedure, debridement of the inflamed mucosa in the nasal septum and the sinuses has been done, and the procedure was uneventful, and the child was shifted back to PICU under room air. And this samples sent our pus culture sensitivity, which showed E. coli growth, and KOH mount of the sample was put, which showed broad aseptate non-branching hyphae mucorales. And biopsy sent showed invasive fungal sinusitis suggestive of mucormycosis. And we have sent fungal PCR panel, which also showed mucoral DNA detected. So some points about mucormycosis. It is actually non-contagious, does not spread from person to person, and it mainly spreads by inhalation or inoculation of the spores. And healthcare-associated outbreaks have been linked to adhesive bandages, hospital linens, or wooden tongue depressor, which we use on day-to-day, negative pressure rooms, water leaks, poor air filtration, unnatural medical devices, or nearby building construction. This shows the KOH mount, which showed non-branching aseptate hyphae. And the invasive fungal elements can be seen inside the vessel wall. Is it fungal elements? So some points about types of mucormycosis. These pictures are just for the study purposes. These are not the pictures of the index child. Types, first is rhinocerebral, sinus and brain involvement, where facial swelling, condition, black lesions can be noted, not necessarily in all the cases, on the nasal bridge or upper inside of the tongue. The child usually presents with fever, headache, lethargy, seizures, slurred speech, partial paralysis if cerebral cavity is also involved. Pulmonary mucormycosis, where the child presents with cough, chest pain, shortness of breath, hemoptysis. This is a CT chest finding showing mucormycosis. cutaneous skin mucormycosis. This usually presents like a blister or an ulcer. The infected area later turns black and associated with the signs of inflammation, pain, warmth, redness, or swelling. The other forms are gastrointestinal, which presents with the GI symptoms, and other forms are disseminated mucormycosis. In this index child presented with mainly with the eyelid swelling, facial swelling, and fever. No other symptoms are noted at this point. So what could be the probable source of infection in this index child? So the potential source for this pathogenic organism, the potential source can be a moisture source. These are the potential source for pathogenic organisms such as bacteria and mold. And as this child presented in the COVID period, there was this could be a possibility. There was a frequent use of distilled water, oxygen concentrate, humidification, which could be a potential contamination source, and there can be a significant contamination in the pipes of the oxygen cylinder. And the other thing, the poor indoor ventilation during COVID, people used to confine to their own houses. This can be the airborne spread of fungal spores presenting in the surrounding environment. And another thing, the child had a steroid exposure, but the duration and the quantity of the steroid which the child took was not evident in this case, which could not trace the back records. Steroid exposure for LRTD, and there was a prolonged diabetes, immunocompromised state. Reason is the child presented to us in the decay. We do not know exactly the duration where the child had the uncontrolled glycemic status. And decay, the acidosis promoting higher ferritin levels, which will be explained later. So why does mucormycosis occurs in DKA? There was 2 to 3 mechanisms that the phagocytic activity of the neutrophils is impaired, where there is decreased chemotactic activity and there is decreased reactive oxygen species production. And this acidosis, pH less than 7.1, which was mentioned in some articles, disrupts the transferring binding to the protein. This leads to increase in the free ion. This is utilized by the utilized by the microorganism, the rhizopus, favoring the rhizopus growth. And this uncontrolled glycemic status, as advanced glycosylation end products increases, the trans-endothelial migration of the neutrophils decreases. And the angioinvasive component, it depends on the ability of the organism to acquire the iron from the host and on its interaction with the endothelial cell lining the blood vessel. So this flowchart depicts, first there is increase in sugars, acidosis. This restricts the phagocytosis of the spores. And through the oxidative, non-oxidative pathways, it promotes the growth of mucormycosis. This similar thing also happened not only in DKA, other immunocompromised state like solid organ transplant and hematological malignancies seen. And the other mechanism, there was oxidative burst dysfunction, which promotes the fungal growth. And this is again mentioned, impaired phagocytosis, free fungal spores. This promotes the growth of mucormycosis. So things, the points to think in this scenario, as already mentioned, this mucormycosis, the growth of mucormycosis is promoted in acidosis environment and uncontrolled hyperglycemic state. But in our index child, this graph depicts the CBG trend. At 36 to 48 hours, the CBG has come down and the anion gap is also around normal. This time the child started manifesting symptoms and the symptoms and the disease progressed in the setting of controlled glycemic status. The points to be mentioned. And coming back to the index child, there was a progression of the symptoms noted. There was an increase in the eye swelling. After FES, there was an increase in eyelid swelling and there was abduction restriction in the left eye and dilated minimally reacting pupil of the left eye noted. So with the possibility of the stage 4-5, which was explained earlier, the Chandler classification of orbital cellulitis, the possibility of compressive optic neuropathy was kept and repeat CP paranasal sinuses and orbit was done, which showed the progression of the disease orbital cellulitis with intracranial abscess extension. This finding was confirmed with MRI brain, which showed the enhancement in the orbital muscles, retrobulbar fat surrounding the optic nerve at the apex, and there was irregular abscess in the basifrontal region. Actually, combination of CT and MRI helps in more accurate diagnosis and an evaluation of the extension of the lesion. So to think for us, on day 1 of presentation, the child did not have any orbital signs or symptoms, and the pupil was absolute. The pupillary reaction was normal, and on day 4 and day 8, there was findings noted in the orbital cavity. So to think, in all patients with mucormycosis, whether orbit is involved or not in the first imaging study, initial and serial comprehensive ophthalmic evaluation is mandatory. So just to look for progression of the eyelid swelling, erythema, ptosis, and regular monitoring of the extraocular movement, pupillary reaction, visual acuity, and the evolution of proptosis and fundoscopy examination by ophthalmologist is mandatory. And this to note, the mucormycosis can complicate the underlying active proliferating diabetic retinopathy and glaucoma. So the active control of the disease is, the early and active control of the disease is needed. So the intervention planned in this index child is multidisciplinary approach. For the intracranial abscess, the neurosurgical intervention was done, which left front craniotomy and excision of the fungal mass was done and sent for the histopathology. And ENT, endoscopic debridement of the paranasal sinus, oculoplastic surgeon left orbital decompression with infiltration of the injection amphotericin, liposomal amphotericin B. So the difficult decision which was made in this child will be highlighted here. Prior to the procedure, the endocrinologist opinion was obtained for the glycemic control, neurologist opinion. So prophylactic anti-epileptic loading levodopa was given, and the procedure went uneventful. PRBC transfusion was given. Post-procedure, child required mechanical ventilation for 24 hours, and the post-op care was continued. And the child was weaned off to room air on the day 2, and IV amphotericin B and PIPAS was continued. And the biopsy again showed invasive fungal infection with granulomatous reaction suggestive of mucormycosis. So the difficult decision which was hindering us is whether, as the oculoplastic surgeon suggested, the orbital excentration was also an option, and conservative orbital debridement can also be done in this scenario. But there was no standard protocol to define whether the child needed this or that. This depends mainly on the physician, the judgment. The factors deciding are the presence of ophthalmoplegia or cranial nerve involvement, ocular tissue involvement, generalized necrosis of the orbital cavity, or the cerebral involvement based on the underlying immunosuppressive disease. In this scenario, the glycemic control was achieved, whereas in case of neutropenia, lymphoma, leukemia, all those conditions, the risk-benefit ratio has to be assessed. And the unsatisfactory response to the initial treatment, even after repeated surgical and medical intervention, the disease was progressing. So finally, the main question to be addressed are whether excentration can reduce the mortality rate, and whether benefits of excentration are satisfactory enough against its lifetime disabling effect. So we did conservative orbital debridement, followed along with infiltration of liposomal amphotericin B. This is the thing. This picture is not the picture of the index child. Just for our understanding, this picture was put. And along with orbital debridement, the local amphotericin B irrigation provides a better outcome. And 3 to 4 ml of liposomal amphotericin B will be given. And risk ocular toxicity of the drug is also there, and uneventful infiltration of orbital components can lead to further damage to the orbital cavity, which has to be noted. And there is another method which could be done. There was a local application of amphotericin B. This is the method where retrobulbar injection can be done when the orbital surgical intervention is not possible or the signs of optic compression was there. The same dose will be given, but the other risk of low perforation and neurotoxicity has also to be addressed. And post-surgery, after the surgical intervention multimodal approach, the child, after this, the PICC line was inserted for the need of prolonged medication as the child disease was progressing and glycemic control was achieved. After 7 days of surgical intervention, repeat neuroimaging was done, which showed subacute hemorrhage in the left frontal lobe of 4x3 centimeter with post-op changes. Here, but the child was absolutely normal. There was no neurological deficit noted. Hence, our neurosurgeon advised conservative management. So the management of post-op hemorrhage, which is very common in the post-op cases in neurosurgery, whether to intervene or not, it depends mainly on the neurological status of the child. In our index child, the child was neurologically near normal and the underlying disease process. This child was operated mainly for fungal lesion and underlying underlying immunocompromised state glycemic status was controlled. And the worsening hemorrhage As the child was absolutely normal, the repeat MRI showed no further worsening. The conservative management was opted in this case. After this, on the next day, the the MRI also showed there was a lesions left in the nasal cavity and the sinuses. So ENT people opted debridement of the left nasal paranasal sinuses with pus, and ethmoidal polyp removal was again done. And the retrobulbar injection, which we discussed earlier, ophthalmologist suggested intraocular injection of liposomal amphotericin B. Twice it was done on day 19 and day 20 to control the disease process. And on day 27, repeat neuroimaging was done, where the MRI showed there was a significant increase in the orbital soft tissue collection and abscess again in the frontal lobe. Here, again the child was taken under GA and left orbital debridement was done. Post procedure, the child was okay. And on the POD1, the child started having fever spikes, and there was again increase in CRP and serotonin, where the blood culture showed no growth. We have upgraded the antibiotic piptas to meropenem, and after the control of the fever spikes, the child received the total cumulative dose of amphotericin B of 2,300 milligram. And after this amphotericin B, the child was shifted to oral posaconazole at 150 milligram per meter square per dose. And this posaconazole dose was continued for next 2 months. And on day 35 of admission, fever spikes got settled, and child received meropenem for 5 days, and the child was discharged on oral posaconazole with normal neurological function. So the diagnosis made in this is new onset type 1 diabetes mellitus with severe DKA with rhino-orbital mucormycosis with intracerebral abscess. On follow-up, the child was discharged on oral posaconazole on 25 November 2022. The child came to us for review on Feb 2023, where again nasal endoscopy was done, the crust, debris, thick pus was removed, and the healthy mucosa was noted. And the child presented to us in the next year with moderate DKA with lower respiratory tract infection with acute flare of the wheeze, which was controlled with nebulization. And for moderate DKA, child received IV insulin for 24 hours, and which was gradually transitioned to subcutaneous insulin. And CNS showed no focal deficit. After the examination, there was a minimal left eye ptosis and extraocular movement restriction. Otherwise, the child was normal. So lessons learned in this thing, not all the fast breathing is not always pneumonia. And in immunocompromised patient, we have to suspect fungal orbital cellulitis. And in decision-making process, whether to do orbital acceleration or a salvage procedure or orbital decompression decision has to be taken based on the benefit for this child. And the other thing, mucormycosis is usually not encountered commonly in a day-to-day practice. A high index of suspicion is needed to avoid delay in diagnosis and treatment. So when to suspect that when there was a sudden decrease in the vision, recent periorbital swelling, orbital or facial pain or headache, when there is a blood mixed nasal discharge, and when there is drooping of eyelid ptosis or ophthalmoplegia, and when there is multiple unrelated cranial nerve palsies. And whenever we see black necrotic tissues in the nasal turbinates, we easily mistaken for the crusted blood. In the setting of immunocompromised state, this has been noted. And missed diagnosis and treatment, missed signs and symptoms are orbital examination, oral cavity examination is very much needed. The periorbital, cheek, alveolar, dental pain, this can present like this, radiating to the ear, neck, and head. The child can also present with hypoesthesia, anesthesia over the cheek due to involvement of the infraorbital nerve, and investigation of the soft colored gingival mucosa for any necrotic tissue is noted. These are the pictures for the understanding purpose, not of the index child. So we have to be aware of the source of the infection. Healthcare associated outbreaks can be linked to adhesive bandages, hospital linens, food and tongue depressors, as already mentioned. So we should also be aware of the masquerading disease, the underlying differential diagnosis. This can be an abscess formation here, or it can be a tumor, benign or malignant, or it can be a bacterial sinusitis, should be noted. Remember, MRI of the PNS, orbital cavities and brain, as well as performing nasal endoscopy is imperative. And the possibility of concomitant mucormycosis with fungal species, Aspergillus and Candida, can also be there. And the need of antifungal drugs are needed. So I'll stop my presentation here.
Thank you, Dr. Sobana. You can stop sharing. Wonderful presentation. I think it's a very interesting case. For Sasi to take over, Vijay Ole sir, your valuable comments, sir.
Before that,
first
I
of all,
really want to thank Dr. Shobna and Dr. Shashidharan for presenting a wonderful class. Over to Dr. Vijay Ule.
so congratulations and thank you so much, Shobna and Shashidharan, for bringing up such a wonderful case. Mucormycosis, especially post-COVID, I believe many pediatricians saw mucormycosis. We also had a patient of mucormycosis. Of course, we have seen mucormycosis in pre-COVID era as well, especially in children who are malignancy children who are on oncotherapy for malignancy. If you look at the WHO definition of pneumonia for community health worker, any child with fever, cough, and rapid breathing, the health worker is asked to make a diagnosis of pneumonia and administer amoxicillin. In the past, it was cotrimoxazole. But of course, time and again, we have emphasized in our teaching modules, which IIP had rolled out way back in 2005 of RTI GEM, and subsequent workshops also, that as pediatricians, we should rise above this and go and try to dissect out different causes of fever, cough, and rapid breathing. It is not at all uncommon to see diabetic ketoacidosis and Kussmaul's or acidotic breathing being mistaken for tachypnea, and the child is mislabeled as pneumonia or lower respiratory tract infection. So that was the first mistake which was done. There was an opportunity to look at the child was hospitalized 2 weeks prior to coming to your center, and perhaps there was an opportunity to look at the blood sugar. Any child with who gets hospitalized, it's a routine practice to check blood sugar at least with hemostats, and maybe perhaps that time because his HbA1c of this girl was 14.1, so she definitely had a long-standing diabetes, and perhaps that time the diabetes could have been picked up. Talking about orbital cellulitis, this child presented in decay, and then you noticed swelling in the pre-orbital cellulitis, and this child progressed. I just, if I remember your presentation well, to me personally, the initial antibiotic choice perhaps was incorrect. This child was started on piperacillin, tazobactam, and fluconazole. A diabetic child can have orbital cellulitis. Not necessarily all diabetic children have fungal infections or mucor, but to have a high index of suspicion is extremely important. But if you look at the common organisms of orbital cellulitis or preseptal cellulitis, one would definitely cover anti-MSS and anti-MRSA agent with a gram-negative cover, of course. And so ceftriaxone vancomycin or coamoxiclav vancomycin would be the, at least I would have started this combination in such a child. The moment you suspect mucor, one needs to be extremely aggressive. You did take us through the multidisciplinary team which was involved, and essentially the decision to restrict excision only to the infected portion or do extensive resection was a decision primarily rested on the shoulders of the intervening ENT surgeon, ophthalmic surgeon, and neurosurgeon. So perhaps had they been little, because we have burnt our fingers twice in the past, trying to be little conservative. I wouldn't want to name, but one of the doctor's child who had a lymphoma was on chemotherapy and developed mucormycosis. And our ENT surgeon, since you invariably get into that VIP syndrome, a known child, colleague's child, it was a little conservative, but ultimately we lost this child. So the point that I'm trying to make is one needs to be real, because mucor is very aggressive and it invariably affects children who are immunocompromised. Diabetes is known to be a good substrate for mucor and other fungal infections. And therapy is prolonged therapy, and it's not all that easy unless you are in the regular of treating such cases. It is better to involve ID experts. By ID experts, I mean not necessarily qualified ID expert, but there are senior pediatricians and pediatricians with good deal of experience in infectious disease, because this involves administering antifungal agents with potential toxicity. It requires prolonged therapy. It requires monitoring. Liposomal amphotericin, posaconazole, or isoconazole. These are the agents which are used. Combination therapy. Not that there are many reports on it, but these decisions are to be taken individualized to the child that is at your hands. And so this perhaps was a decision which the operating team could have been a little more, radical. And fortunately, the child could make it, and the child came out of woods and was successfully discharged. So an excellent case, and that is all that I had to say. And I had a lot of learning from this case. And thank you once again, Dr. Tangavalu, Dr. Sasidaran, and Dr. Shobna for sharing a wonderful case. And I'm sure all of us had a lot of learning out of this case. Thank you.
Thank you so much, sir. Thank you. Vasant, sir, anything?
Yeah, tell me.
I say ID specialist. What is your, sir?
Yeah. No, thank you. It's a lot of learning, and that was my basic aim. We should learn. And for here, so many cases we want to definitely keep this case as a preserved case, and we can have this case permanent case in our app and our library, so that we can share it anytime to such cases. So you can continue, Dr. Singarvelu. Thank you, Dr. Shashidhar Shobna, definitely, and thank you, Vijay, for your expert comment. Thank you.
Yeah,
Thank
that
you,
would
sir.
also be my suggestion. Singarvelu, please archive these cases and
Yes,
make them into a library so that those who are unable to join us online can view them at leisure later on at their convenient time.
Yeah.
And there will be a
Surely,
lot
sir.
of learning. And nowhere in the case it is mentioned that somebody has committed a mistake or made a blunder. And there's a lot of learning out of this, and this is how the cases should be presented and discussed. I'm extremely happy about it.
We are really proud,
Can
sir,
I
and
give a
honored, sir.
comment, please?
Yes, madam. Yes, madam.
Can I? Sorry.
Yeah, Neelam,
I just
please.
wanted to say, because fortunately or unfortunately, we also got to see a couple of cases because in post-liver transplant setting. And I just wanted to highlight and, make it a learning, because I had seen one orbital, and just exactly like this case, we were able to save it, salvage it, and it was sorted. Once, if you see mucor in the gut, it's very difficult to salvage and there. So we should have an extremely high, narrow line where you should do in, because these cases, when we retrospectively thought we lost the child, we had done an endoscopy. The child had presented with a little vomiting of blood. And in that, they were, in the endoscopy, we picked up that there was black fungus. Subsequently, we were wiser. But I think it is very important, if you think that the patient is immunosuppressed, then in that case, you should be extremely vigilant to see that the other organs are not involved. And that's the message I want to give. Because when it was limited, we could save. But when it was in the gut, we could not save 2 cases.
The main purpose of this case, as Vijay sir correctly told what our president gave.
So doing the endoscopy early, when in fact, when we went back and saw that actually in the endoscopy they had seen it, but they could not interpret. My youngster could not interpret. He thought it was something black necrosis, he thought. But he could not. Later on, we could correlate, that could have been an early fungus.
Neelam, the best decision was to early fess and obtain the tissue and subject it to
exactly.
biopsy.
That is what I'm saying. So that has to
molecular testing. Molecular testing was also done.
Extremely aggressive.
Extremely
we
well
have
managed.
to be totally
They were
agree.
very aggressive.
Very
well
aggressive.
managed, in fact. Yeah.
Learning point for practitioners, sir. Even I have come across several cases which presented as, referred to as CNS infection. Sir correctly said, whenever we come across a very sick child, doing a blood sugar is not a good investigation. But noted as a routine, because as diabetes is very rapid everywhere, this is the main message which we want to give to the practicing pediatrician. As we could have prevented such a devastating procedure and other things, we could have diagnosed early. Thank you, sir. Sasi, sir, final comments. Next, we go to the next.
I think everything has been very in detail discussed. So Vijay Avli sir's points were like very, very important. Basically, the initial antibiotic decision making, obviously the anti-staph cover, empirical anti-staph cover, the two MRSA cover would be the right on the board. The other thing is what we thought as learning points. I'll summarize those 2-3 learning points what we had through the course of managing this child. Number one is very simple respiratory distress versus acidotic breathing differentiation. And if we are not able to differentiate, at least doing a level extra investigations like blood sugar testing is not, we cannot call it as a level extra investigation, but a basic investigation. These things would have guided us. Because it is a kind of post-COVID period, everybody thought that every respiratory distress is pneumonia. Though it was applicable only in adult patient during that time, they considered this child also as a pneumonia child. So that has created more problems. Second thing, what I want to highlight is, though we think that oxygen delivery is like innocuous, it may not create much problems, but oxygen delivery, nebulizations, about the filter, cleanliness of the devices, this also has to be given a significant importance. And another thing is about giving a steroid therapy when we are not very confident that it is really what is the disease process. So this child has a steroid exposure. So these three things, maybe I can say as learning point for everyone, all people who are involved in pediatrics. One peculiar thing is in this child, basically everybody will wonder that this is predominantly a oculoplastic surgeon, neurosurgeon, and ENT surgeon's forte. So they are deciding everything. So why we say that there is a learning for pediatricians? Basically, we also initially thought like that. But when the best pediatric ENT surgeon, when the best pediatric neurosurgeon, and best oculoplasty surgeon came, they told that we have never seen this kind of cases at 3 years. And especially, as Yavli sir told, in oncology, we see all these things, but in non-oncology patients, we do not have experience. So every decision required a pediatrician input. So these are all 4-5 things what we learned, and we want to communicate to everyone in the forum. Thank you. Thank you for that.
MDT is extremely important, multidisciplinary team. And secondly, as a dictum, mucor needs to be handled very aggressively. If you don't get aggressive, mucor gets aggressive.
Thank you, sir. Lot of inputs in chat box, sir. All very positive comments, and a few have given very good. Whether the child has done immunological workup, whether immunodeficiency was thought of, what they have done, and energy component, anything is there. This is what and a lot of positive inputs, sir. I think, Tangal sir, if there are no other comments, we'll go to the second case, sir. Tangal sir.
Just a minute, sir. Whenever we see as a general pediatrician, see a child with fast breathing, 3 things will differentiate DKA from respiratory distress. One is a child who had deep inspiration, deep rapid breathing will not occur in any respiratory conditions. It does not allow deep inspiration. Second is absence of retractions or minimal retractions. Third is presence of normal saturation room air. These 3 things will differentiate. This is not a respiratory condition. It is a non-respiratory condition. Okay, sir. I just finished my comments.
Dr. Tangavulu,
Yes,
thank
sir.
you so much for those pearls of wisdom. And this is exactly what I was taught by my registrar when I was doing my post-graduation. So the impressions which are created on young minds last long. And due respect to all the pediatrics, if you follow what Dr. Tangavulu said, it's not so very difficult to differentiate an acidotic breathing from, tachypnea of respiratory cause. Thank you, doctor. Thank you, sir, for those
There's
comments.
something on the smell also, Dr. Thangavali, that you want to add?
Yes, madam.
Fourth thing we used to be taught about the breath.
Yeah.
Fruity smell.
Yes, so
Thank
that
you,
was the fourth we were also taught.
Thank you.
Sir, can I ask one question?
Thank you. And the words of wisdom of Yavle sir and Madam Nilama gives a lot with the final conclusion. Definitely, it made a very big success to all the learning.
Singularly, Dr. Parmanand wants to ask a question. Please allow him
Yes,
to
sir.
ask something.
Yes, sir.
Yeah.
Sure.
Sir, can I say thanks? It's a nice case, sir. I just want to ask the expert, is this initial thought process when the patient presented, whether it was the thought of the orbital vein occlusion with the decay, because the decay would have a dehydration with hyperviscosity,
and which is one of the factor which can lead to occlusion, or it was a second two infections together, one like two things together. One is a decay with a COVID, and with COVID we knew that it's a vasculitis which was causing this occlusion and the use of oxygen. And that time, what one of the cause for the orbital mucor. So is the decay per se which led to this issue, or whether there was some other etiology, pathophysiology, or two infections together, or decay with COVID. These are the possibilities. This just wanted to give more on this. Thanks.
What was the COVID status of the child?
COVID, sir, COVID status was negative in this child. So
because the child came in 2022, right?
Yes, sir, 2022, and this child COVID status was negative, and
COVID antibodies.
COVID antibodies also. This is the season we do COVID antibody test and COVID screening for all patients, sir. So this was not part of a MISC spectrum. This is not part of a primary COVID. And another thing is, that is why I think we have highlighted in the presentation, but it was little it was very fluid. It was not given that importance. Basically, our concern was this child DKA has got settled, and then only the orbital swelling has become quite significant. So the orbital vein occlusion presenting like unilateral swelling is a very good possibility for DKA in the acute state. But when the DKA is completely settling,
even if they're dehydrated in recovery, they can present later on. Like initially, because it's a hyper viscosity at that time, an occlusion. With the first go to, we can think of an occlusion rather than, yes, definitely with MRI, we may have a much more information about the fungus.
Okay.
I think I agree with Parman, that's an extremely good thought. However, I mean, when you say that it came up when the decay was settling, with reins in your hands of titrating insulin and managing the child, obviously the sugars would come under control, even the acid would improve. However, I mean, how relevant is that statement that the decay was settling and then the orbital cylinders came up?
Because when in decays there is a dehydration component related complications also. Because when the orbital vein occlusion
from
happens,
that angle, I got
it is because of the dehydration.
Okay,
so
from that angle.
8.5% dehydration.
Yes, sir, he's right, but only thing that there can be an occlusion to start with. The symptoms can appear little later on. So even though the dehydration got corrected, the occlusion can be there, and the symptoms can appear little later on, as there is the moment there is a compression on the blood supply, it's not getting drained, the symptoms can appear little later. So you may not be able to start with.
And I believe the management would not change, but subsequently.
No, it will not change. Only the MRI would tell in that initially thought process. Only we may have to give some the Clexane or other the thinner agents to start with, and you may lose the eye or you may lose the vision.
True.
Thank you, Paramanand sir, for your very, very valuable inputs. I think a lot of comments in the chat box. So with this, we'll go to the second case. Very interesting aspect after managing corporate level cases. We are practicing pediatrician who is in a rural area over a period of 3 decades, who did MRCP from practicing in a rural area after 25 years of practice, and who won the pediatric quiz in the year 2007, true disciple of Dr. Ambedkar. The man who brought Ambedkar sir several times to Tamil Nadu for several programs is none other than Dr. Paniram. I think Avade sir also will know about Dr. Paniram's physical acumen, because whenever Avade sir conducts any program, he will be there. And so now he is going to present a short case that will be more useful to the very grassroots pediatrician practicing in a periphery. Paniraman, over to you, Dr. Paniraman. You can start sharing, sir.
First of all, I thank our National President, Dr. Vasant Kalatkar, the coordinator, Dr. Singarvelu sir, and the expert, Dr. Vijay Avle sir, and the and the chief guest of the meeting, and everyone and Dr. Thangavelu for giving the opportunity to me. And one fine evening, suddenly he called and he asked me to present any important case you've seen and you have missed or thing. So thank you, sir. And I'll try to, and after a very turbulent, tough case, now we will go through the simple cases which we face every day in day out practice. Now I'll share the screen. Is my screen visible? Am I audible?
Yes, yes. Go ahead.
Yes. Okay, sir. This is one patient which I seen in 2019, and I brought with a 2-year-old child with a history of delayed walking and now walking with abnormal posture. That was the complaint. And initial motor milestones were normal and delayed after sitting, that not walked even a few steps up to 18 months. And other domains of developmental were normal. No history of perinatal insult or neonatal encephalopathy. So this was the key complaints. Just a minute, sir. Okay. So clearly there was no perinatal insult or neonatal encephalopathy, everything. So which clearly we know that mostly the cerebral palsy is ruled out. And by other domains of the developmental domains were normal. So like intellectual disability or global developmental delay, that is also mostly ruled out. And initially the child was doing well reasonably. Then only the child had developmental delay. So this type of delay is very common in practice, because in practice easily you can pick up a cerebral palsy. Everyone easily diagnosed with a hypertonia with the history of perinatal insult, and immediately you can come to a conclusion. And in the practice, you can easily mix a developmental delay, particularly isolated motor delay, with a hypotonia, with a weakness, and like a spinal muscular atrophy, easily you can diagnose. But as a practitioner, what things like benign and subtle things which are treatable in the practice you should be aware of. For example, nutritional things like vitamin D deficiency or rickets presenting after the stage of sitting or standing, you can have a subtle delay you can have. And vitamin B12 deficiency presenting as mainly the motor delay, as well as with some other symptoms we can also have. So these things should not be missed in practice. So vitamin D deficiency and vitamin B12 deficiency. And number 2, neuromuscular causes. Also, for example, benign congenital hypotonia is a diagnosis after mainly exclusion. That is also can occur, particularly in case of in a practice. And sometimes even Duchenne's can present in the early with only mild delay in the particularly in the walking. So only when you do the CPK will be raised and you come to the conclusion. The Duchenne in the early stages can present like this. So these are the neuromuscular causes. And finally, you will come across, for example, causes like a joint causes, like a hip joint causes like DDH, as well as you come across joint laxity. In a case of hyperlaxity syndromes also, they can have a delayed walking. These are all subtle developmental delay with respect to mainly the isolated motor delay, which we come across in practice over a period of time. So in this patient, the head circumference was normal. There were no signs of manifest rickets or vitamin B12 deficiency. Neurologically, the bulk, tone, power, and DTR was normal in both the upper and lower limbs. So hypertonia conditions are ruled out, hypotonia conditions are ruled out, rickets I'm not able to find it out, anything like knuckle pigmentation, etc. B12 deficiency I was not able to find out, and had a clue in the form of spine. There was excessive lordosis with the waddling gait. That was the only clue which we had. And developmental assessment, objective assessment, other domains were normal. Clinical impression, it was isolated motor delay for evaluation. After seeing this video, you can immediately identify this was a everyone can appreciate the excessive lumbar lordosis as well as the waddling gait. So after examining the child, it definitely gave a clue that most probably I am dealing with a hip joint problem. And then later I found that there was a restricted abduction also. I found another sign. So restricted abduction as well as excessive lordosis and the waddling gait and mainly the bilateral. So mostly it turned out to be a case of neglected DDH. And you can see the X-ray hip clearly showing actually the head of the femur is shifted upwards and posteriorly both the sides. It was a case of bilateral DDH, developmental dislocation of hip, neglected developmental dysplasia of hip is this patient. So what is the new in this case? What you are learning from this case? So whenever you went to suspect, but whenever there are risk factors like first female baby in a breech delivery in a family history of DDH, we should always suspect. Whenever there are asymmetrical skin folds in the upper thigh or limb length discrepancy, you should suspect unilateral DDH. In an older child, any child walking with a painless limp and Trendelenburg gait towards the affected side, you should suspect. Why should we diagnose? Because if we won't diagnose, naturally they will go for lateral, mainly degenerative changes and early painful arthritis. Early treatment within 6 months is very safe and successful with less complications. But how to diagnose? By screening. Screening is clinical. And Artoloni and Barlow procedures before 3 months. After 3 months, limited abduction after 3 months. And mainly the Galassi sign when you make the child to put flexing the that is in the hip joint as well as flexing mainly the knees in the flexion. See the level of the knees. At the level of the knees, one is higher than the lower. That is the Galassi sign. Or signs of bilateral DDH, including hyperlordosis, bilateral Trendelenburg sign, and the presence of Trendelenburg gait, like in this patient. And the peculiar point on this case is mainly the spontaneous resolution. Dislocatable hip, when you diagnose early, that is Barlow's maneuver is not a very, very important thing. Why? Because sometimes dislocatable hip will resolve by 3 to 6 weeks. So only the dislocated hip has to be intervened early. What happens if you do unnecessary treatment or unnecessary aggressive management? What will happen is avascular necrosis of the hip can occur whenever you go hastily for the management. So only we have to balance between the both, whether we should manage aggressively or thing. So screening of the DDH, and no newborn screening programs have eliminated late diagnosis. And it is a poor sensitivity and poor specificity. So only the current recommendation is repeated hip examination at 2 weeks, 2 months, 4 months, 6 months, 9 months, and 1 year from the American Academy of Pediatrics. And the Canadian Task Force clearly recommends serial examination of the hip in infants under the 12 months. What about Indian thing? And the Indian Pediatrics and particularly the consensus guidelines from Pediatric Orthopedic Society of India, like Taral Nagda from Mumbai and other people, IAP, NNH have clearly came out with a guideline statement. It is no more a screening. It is a surveillance of developmental dysplasia of hip. Even if you miss in the neonatal period, no worries. You have to do a periodic checkup of the hip joint over a period of time, particularly whenever they are coming for immunization visits. Do a limited abduction test. When it is positive, you go for the confirmatory ultrasound and then refer to a pediatric orthopedic surgeon. So screening tests are false positive, false negative, plenty of things. So no more it is a screening for DDH. It is only a surveillance for DDH. That is the important message from this case also, as well as the current concept also. What is the role of the ultrasound? Ultrasound is a oversensitive test. So only it is advised not to do ultrasound up to 6 weeks of age, even when high risk factors are there. So its role is only to confirm your clinical examination, clinical findings, not to go ultrasound at the first start. So only particularly that American Task Force has clearly told no role of screening ultrasound in a newborn for DDH. There is no role for screening ultrasound. What about plain radiographs? Mainly as the time grows, the femoral head ossifies, acetabular head ossifies. By 4 to 6 months onwards, the plain X-ray is the best procedure to mainly to detect the DDH. As in this case, you have seen in a 2-year-old child, how clearly you have seen that mainly the DDH. Management, we all know we are going to refer to the pediatric orthopedic surgeon. Finally, the carry-over message is suspect and intervene only when there are definitive signs of DDH. restriction of an abduction is an easy way of detection for a practicing pediatrician, particularly from the second immunization visit or a third immunization visit. From 12 weeks onwards or from 8 weeks onwards, go for the limited abduction test. That is the easiest way one can diagnose, because in the newborn, because of getting a calm newborn and a calm surgeon or a calm physician is very difficult, particularly for the Ortolani and Barlow procedures. Definitely they are challenging procedures, but even if you miss the opportunity of newborn, no worries. It is going to be a period of serial observation. That is the message. Aggressive detection and management is not warranted. Particularly, they have shown mainly the avascular necrosis is so common, particularly with the aggressive diagnosis. So no need to aggressively diagnose. So surveillance rather than screening with the periodic examination till the child is walking is the current concept for developmental dysplasia of the hip. Again, I repeat, surveillance over a period of time till the child is walking, every immunization or every well child visit until the child is walking is the current concept for developmental dysplasia of hip recognition as well as management as a timely basis. And confirmation is only by imaging less than 3 months, ultrasound after 3 to 4 months, mainly by plain X-ray hips. The sources, mainly American Academy, another thing, and Indian Pediatrics, March number 2. So not only these things, and because of another few case snippets I want to mainly share, because which no one should miss in their lifetime. Because this I have missed long back in the year 2000, when a 5-year-old child has brought with a fallen from a height and hit the table while falling with impact on the eyeball and the forehead. When I examined, there was no obvious sinister signs. Pupil was acting and there was no hematoma, no contusion. I immediately, but still father was insisting it was an eyeball injury. I referred to ophthalmological for evaluation. The ophthalmological took it lightly, and over a period of time, the child developed blurring, and finally the child turned out to be a case of retinal detachment and lost his vision, because retinal detachment following mainly the closed eyeball injury is a painless thing. Over a period of time, the child develops the signs, which unless you are aware of, it will lead to loss of vision. Because presently, that child is doing MD internal medicine in a prestigious medical college, is finally a postgraduate with a disability of one eye. So message is, whenever you are facing a trauma, particularly the facial trauma, subtle eye trauma, any global eye trauma, be careful not to miss such a thing. This is a very disastrous experience I had in the past 20 years or 25 years. Another thing is, and the abdominal pain is one of the very Pandora's box everyone knows. This is a child, 5-year-old child with a vague abdominal pain of few weeks duration, evaluated at different levels. Even abdomen was opened in a higher institution, and finally the abdomen was opened and finally found nothing, and finally turned out to be a case of paravertebral abscess and part spine. And so such is the mainly the vagueness of the abdominal pain, and you can get a different diagnosis, like an adolescent and having abdominal pain, having a high BP, presenting as a chronic renal failure or a chronic fibrocalcific pancreatitis, nephrolithiasis, and even lymphomas. So beware of surprises while managing abdominal pain in children. So these are, I thought, because of the time limits, I wanted to share some, mainly the case snippets which I had come across in my practice. So abdominal pain, so always be careful, have an intuition, have a lateral thinking whenever you are facing an abdominal pain, blunt injury phase, and always see to that you are not missing mainly the eyeball injury, and see which can easily painless retinal detachment and loss of vision. And finally, this DDH, what is the current concept I have shared in the thing. Thank you very much for the opportunity. Thank you, one and all.
Thank you, Dr. Palanu. Really, it's a wonderful class and a different experience. I think from next time, we should have a short presentation, at least 4-5 cases like you. And we will definitely give you a chance to present remaining cases also when we will have a time. Thank you once again. Thank you. So over to Dr. Vijay Ule.
Yeah, it was great, and it is always great. I have learned a lot from Palni Raman, and my salute to him. I mean, despite being not formally attached to any academic institution, he's one of the finest academicians that we have in our country. And he, with the kind of experience that he has had. And thank you, Palni, for sharing those short cases. And I think my suggestion would be, every time we have 2 long cases, let be a small snippet from Palni Raman. He has a huge collection of cases, and I'm sure that would benefit the practicing pediatricians. So thank you so much, and I cannot agree more on what you talked about the DDH, which is because about 3 or 4 months ago, I had a similar child where DDH was missed he had been to pediatricians for vaccination. And the point that you made, that screening and repeated evaluation at the time of vaccination is a great opportunity for us to, look for a missed DDH. And that would be really a great saving for a child. And your painless maternal detachment and the renal failure abdomen. I mean, points have been so well made. And it was a great learning from none other than Dr. Palni, an astute clinician and a great practitioner. Thank you so much.
Thank you. Thank you, Vijay. Thank you very much. Thank you.
Yeah.
Thank you, sir. Thank you. Thank you, sir. Any final comments, sir?
Yeah, I agree with Professor Vail. Palniraman has got wonderful sense of clinical acumen, as well as he uses the microscope. He's a pediatrician, uses microscope and looking at a smear. That is another fantastic thing. Many of us, even from the tertiary care centers, should learn that habit from Dr. Palniraman. We insist our postgraduates to go to lab and look at the microscope. One more abnormality, one more rare thing we might likely to miss. Yeah, any girl, it's a unilateral pain. Always think about torsion ovaries also. That is also likely to be missed. That will cause very serious.
I had one patient also, sir. I had one patient also.
Okay, over to Singarvel, sir.
Thank you, sir. I think Vijay sir concluded very nicely. Before going to the final, one word from our Pramod Joke, sir. Always, if the joke is some permission of sir. Sir is there, past present. One word, sir, then we will go to that.
Oh, yes. Thank you. Actually, it is, a very great thing that Dr. Khalatkar has started. And I have been listening right from the beginning today. So there are certain important things. One, everybody is saying that learning through mistakes is the only important thing because we all learn more from the mistakes. And another thing is do not commit the same mistake twice. You can commit one mistake once. That's why I keep a diary in my pocket and note down the mistakes that I usually do. Number 3, not to learn from the mistake is the biggest mistake. Okay, so that is very important that you should learn at least from the mistake. And we always say that eyes do not see what mind does not know. Okay, but eyes will not see, the mind does not know. That is true, but the mind will know only if they attend this EEE program. So it is very important that the mind should know, then only the eyes will see. So for that, it is important that this program, Education by the Essence of Experience, is going to be a super hit during this particular year. And I particularly congratulate Dr. Khalatkar, Dr. Singarvelu, the team of Dr. Thangavelu, and then snippets by Palniraman. Everything is going to be a super hit because everybody is interested to know where he commits the mistake. So we will try to attend almost all the programs, and I wish all the best for this endeavor. Thank you.
Thank you, sir. Before winding up, Vasant sir, your remarks, sir. Final.
I think Dr. Pramod Kulkarni is there.
Yes.
Pramod.
Yes.
Good.
Pramod Kulkarni, sir, has given a lot of inputs in the chat box.
Yes, sir. Pramod is there.
Thank you very much. And Vasant, this is the first day of anybody's tenure, let me tell you. Fantastic, fantastic. Thank you so much. Thank you so much, Vasant.
Thank you. Thank you. Atanu is there to say vote of thanks.
Atanu sir left, sir. I am doing his work, sir.
Yeah, you can.
Yes, sir. Now we have come to the final part. Today being the launching of it, this program is a bit extended, and our president was very clear that within 1.5 hours. It was too long session because it will affect our units and all that. That is the reason. And the next meeting will be definitely announced early after discussing with our team members and our president and other office bearers. Here, I would like to thank the presence of our past national president, Dr. Starting from Uday Badakar sir, Dijan Sastri, Upendra sir, of course, our Basavaraj sir, and we should thank our chief guest who readily accepted because Vasant sir wanted to, within a short time, he wanted our chief guest, he accepted. And Avle sir was an expert person who aptly described because everybody learned a lot. And a lot of comments by all our past vice presidents, starting from Satish Sharma, all the present presidents and experts like respected chairperson S.S. Rawat sir, Pramod Kulkarni sir, Sandeep Joshi sir, Santanu and Divyang. So many people has given very good inputs, and it is not only in Zoom, it is also in YouTube. And our action plan chief coordinator Nandish made his presence, and Amulji all were present, and Jitu as usual he has done extremely well. And our president elect is going to given a lot of good prints, Dr. Neelam ma'am. I think if we start mentioning everybody, it will take a long time. I should thank on behalf of our president and the team members who were selected to the core group he has formed to support this work go on every month. 10 members he selected from each zone. From each zone, the cases will be presented accordingly with proper scrutiny and with advice of Dr. Tengavelu and other experts. Definitely, this is going to be a very good expert, and even the first day, we are very happy that all experts joined on the New Year Day, and I am very blessed to have all of you, and thank our Vasant sir for giving us this opportunity. With this, we will conclude today's program, launching of our
Sir,
EEE program.
one thing, with permission of the chair, can I say one thing?
Yes, sir.
Yeah, before that, I want to say really thank you, Dr. Singarvelu and Dr. Thangavelu for taking extreme efforts. Really, I was him after since last 6 months. But what is the charisma? What is the magic he had done? This is in last 15 days only we could do it. Thank you, and I expect Jog sir next time your charisma should be there. Yeah.
Sir, I congratulate Dr. Vasant Kalatkar and his team for this wonderful start. And beginning, it will become a very popular program. I have one suggestion: if we can keep the timing little earlier, at 3 p.m., that will be more suitable for practitioner. So rather than 4:30, yeah.
Yes,
Even
sir.
my suggestion.
A lot of discussion gone, sir. As you rightly said, definitely with the president, we will review the timings, sir, because to start with, sir, more than 100 people, as a program gone, many people even called and message that we are leaving for clinic like that. So with our president and the team, we will discuss and change the timings after his permission, sir. The date
Thank you,
also,
sir.
we will inform you early, sir. Your suggestion is well taken. Definitely, I will discuss with them. Thank you, sir.
Thank you, sir. Thank you.
Thank you. Thank you, well, sir. We can conclude.
Nothing, sir. Nothing, sir. Nothing from my side, sir.
Thank you, Yavle, sir. Really, sir.
Thank you. Thank you. I would say.
You made it very useful to all our practitioners, sir. Thank you, sir. Thank you, sir. We'll
Thank you.
Thank you, sir.
Thank you.
Thank you, everyone.
Thank you.
Bye-bye. Thank you.
Yes, sir. Thank you.
Thank you. Bye-bye.
Bye.
Thanks, Dr. Singaruvel, sir, conducting exceedingly well this program.